everyone, this is Amanda Moore from the Angelman Syndrome Foundation, and you're listening to the ASF Podcast, the show that explains everything you want to know about Angelman Syndrome. We're so excited you're here, and we hope you enjoy the show. For this week's podcast, we have repurposed a webinar that was recorded in years past, but the information is still very much relevant today. We hope this information helps you on your journey. Enjoy the listen. Welcome, everybody. I see everyone's trickling in. For those of you who are joining us right now, you are in for a treat tonight. I am incredibly excited to welcome our amazing panelists. Also, I wanted to show you guys tonight, I'm wearing one of the great things that you can get from the ASF store. Our colleagues tonight who are on the call are all going to get one of these awesome sweatshirts as a thank you for being on our call tonight, but you can find that information on the conference site. So I'm going to stop talking because this is a great panel. We have a lot of information. I know we're going to have a lot of questions. I want to encourage each one of you to, if you have questions, put them in the Q&A box, or you can put them in the chat box, wherever you want to put them. We'll make sure to try to answer as much as possible. But I want to introduce once again my amazing friend and colleague, Dr. Liz Gilazzo. I will call her Liz, to moderate this amazing session tonight around medical care for all ages. So Liz, take it away.
Awesome. Thanks, Amanda. I will say, Amanda, I'm glad I didn't order that sweatshirt from the pop-up shop today. I ordered some other sweet swag, so everybody should go check it out.
Awesome. Yes.
Feeling great this year. I am thrilled to be here tonight as your perpetual host of the week, or your moderator for all these medical sessions. And tonight we're talking about medical care for all ages. I am joined by three fabulous clinicians from the 15Q Clinical Research Network site. So Dr. Duis is a clinical geneticist at the Children's Hospital of Colorado, and she leads the Angelman and Do 15Q clinic there. Dr. Mark Specka is a child neurologist at Rady Children's Hospital in San Diego, and he leads the Angelman clinic there at Rady Children's Hospital. And Dr. Elizabeth Berry-Kravis is a child neurologist as well at Rush Hospital, or Rush University in Chicago. So our goal tonight, as it has been all week, is to get your questions answered. And so we have collected a few questions from the community already, or commonly asked questions in the community about medical care. But please don't be shy, as you have not been all week. Use the Q&A box. We will try to keep up with it. Use the chat box. We have not entirely figured out how to take people off of mute when they raise their hand. So if you raise your hand, we will direct you to the chat box. We don't know how to handle that. So I'll just be straightforward. If we don't get to your question, there's a couple of different ways questions may be answered. Sometimes somebody who's not answering a question may respond directly back through the Q&A. If we don't get to the questions, if we get a big backlog, we'll make sure that all the questions get answered and back out to whoever asked them. So we have a lot of topics that we could get to tonight. Like I said, we're going to talk about medical care for all ages. This means no age is off limit, no issue is off limit. I will highlight that tomorrow night's session is about anxiety and behavior. So if there are particular anxiety and behavior questions, those could be held until tomorrow night. And then Friday night, we will focus exclusively on seizures. And so not to say that we can't answer seizure questions tonight, we absolutely can, but Friday night we'll be talking about all things seizures. So, you know what? We will go ahead and get started. I'm going to actually put Dr. Duis on the spot here because I'd love for her just to give us kind of a top three medical complaints that you hear when patients come to visit you in a clinic, kind of the most common three things you hear about for a patient with Angelman syndrome.
Thank you, Liz. So I would say the top three things that we hear about would be sleep. Either awakening at night, difficulty falling asleep is less common, but sometimes we just hear about overnight being up pretty much all night. The other thing would be behaviors like pinching, hair pulling. And then the third thing, often I would say, is more cognitive things like communication and development of speech, and what are the best ways to help facilitate their child communicating.
All right. Fabulous. How about Dr. Naspeka? What are the kind of three most common things that you feel like you're hearing about, or three other things? Any other issues?
So, so one of the big concerns is that people come to me for are seizures. Okay, and then after seizures, I think the other major issues are sleep, as Jessica mentioned. Behavior challenges are more of an issue, I think, in older school age kids and adolescents. And then the other major issue is communication. But they don't usually come up to me and say, hey, Dr. Naspeka, how can I help my child to communicate better? And there's a wonderful program through ASF to try to help people get local resources to improve communication skills. And I think that there's an entire session on the weekend about that, right? So,
Yes. Yeah, there'll be a lot of series over the weekend about communication and other resources that the foundation provides.
Yeah.
Great.
And then less common problems are like constipation.
Yep. GI issue.
And they know I'm a neurologist, but I think some of them know that I used to be a snotty-nosed pediatrician before I became a neurologist. So I'm not afraid of getting out of neurology into other realms. So
absolutely. I know I speak for Jessica and I when I say the same. I think some of our fondest time was as a snotty-nosed pediatrician. And so we enjoyed tackling some of those other more general pediatric issues as well. All right. And last but not least, any other glaring issues and kind of overall medical concerns that you hear about?
Yeah. So as the neurologist in our Angelman Clinic, I see probably the first thing that people come to see me about is seizures. But I will say that I have been seeing a lot of older patients because our clinic does have a fairly big focus on that. And those patients mainly see me and not the developmental behavioral pediatrician. And so I've been really seeing a lot of non-epileptic myoclonus, which is a very hard problem to treat. And if patients have that, that is often their top concern. So a lot of that. And then all of the same things that everyone else sees: sleep, constipation, behavioral issues.
So let's jump right into that. So there's a question in the Q&A box already, a great question about a 38-year-old with who's developed total body stress tremors. They occurred, about 6 months ago, and the neurologist is certain that they're not seizures. They're different than the hand tremors that she's had since about 6 months or for 6 months. They're total body and they're controlled by emergency Xanax. So let's talk a little bit about tremors, what those might look like, what patient population we're seeing those more in, and what are potential ways to combat those.
Well, I think those, it sounds like that may be non-epileptic myoclonus. I mean, I usually have the families do a video and send it in to me if they're having some kind of unusual and new tremulousness. I mean, I have patients with this kind of thing that goes on like for long periods of time, even days. And it's benzodiazepines do work some for it, but it's a thing that's pretty hard to stop. And I think now the ASF has funded this new project on non-epileptic myoclonus, where videos are going to come in from all the adults that are having this kind of tremulous episodes, and they're going to be classified by movement disorder neurologists, and we're going to get a really good idea of what movement people with specialized in movement disorders, how they would classify these kinds of shakiness episodes, but we've been referring to it as non-epileptic myoclonus. And the reason it's not epileptic is that if you put an EEG on the patient while they're doing it, there's no seizure activity that correlates with it.
Cool. So breaking that down, that myoclonus is this kind of tremulous, jerky movement, and then we don't see that epileptic change or those EEG changes that are associated with seizures with it. Jessica, we're going to add something?
I was just going to add that for a lot of individuals that we're seeing with non-epileptic myoclonus, it's been really key to figure out some of the triggers. So, for example, we've had some kids who have been really constipated and had reflux. And so getting some of those other things under control that could be contributing to discomfort has helped at least the intensity and number of episodes they're having. Other things have been sleep. And then the other thing that we're seeing is sometimes it's associated with a change in their mobility. And so some of it could be that they're having some pain. We've seen some kids who are maybe related to this next question, but who have walked up on their toes for a long time. And so getting more and more difficult and more painful to put their feet down flat on the floor. And so anybody that kind of triggers that either by some of those pains by moving them or picking them up or having them try to walk can initiate the non-epileptic myoclonus. So taking care of those issues can help ultimately treat that problem.
Interesting.
I would second everything that Jessica said, because I agree. There have been some kids I've had who have had a major reduction in their non-epileptic myoclonus once you have treated their constipation or what, as best we can tell, maybe reflux. So the other thing for families to know is that this tends to be a problem of older kids and adults.
What does that mean?
Have,
what age? What age does that typically?
I'm talking about junior high age and older.
Okay.
In general. I mean, every now and then we'll see a younger child that has bad non-epileptic myoclonus, but most often it's in that age group. And I have no idea why that is.
Yeah.
And so if your child is having what are called myoclonic jerks, where they're doing this, they tend to do it for a shorter period of time. It tends to be more sort of discrete and jerky than the non-epileptic myoclonus. And it's more likely to be a seizure phenomenon, which in a way is good because that tends to respond better to medications than the non-epileptic myoclonus does. So,
one other thing I would add to the age of onset is that in some girls, we have definitely seen that it correlates to the time when they start menses or right before they start menses. And for some of our kids that we're seeing, we've seen that if we regulate their menses, that can also help with the frequency of episodes and the severity.
Yeah, I think you also get more of it when patients are anxious or going through a stressful time. It's kind of just there's more sympathetic activation and more adrenaline getting released, and then that kind of aggravates this problem. So a lot of things that you can try to control. Sometimes we get better control just by reducing anxiety and behavioral angst as well.
That's what I was going to say. I wonder if that's perhaps why benzos might be beneficial in some cases, if they're helping to manage anxiety. Okay.
Yes. Liz, if I could just add, we because of a very generous donor, we've been able to speed up that study. So some people have asked when, like, how can I send that? How can I send videos? How can I be involved? Because obviously, this is something that has been very impactful for the community. That study, the information of that study is going to be released any day now, and so we are very thankful that people are willing to participate. So stay tuned. Because of a generous donor, we've been able to speed that up a bit.
Great. And that project is being led by Dr. Carson at the Vanderbilt Angelman Clinic.
And I'd just like to add something to that. The purpose of that study is to really characterize the condition. It will be an essential foundation for then developing different treatment protocols specifically for that. So as you enter the study, you just modify your expectations. It's not going to result in a magic bullet to stop it. So.
Well, I will say there's a lot of interest and discussion from the community over the past 2 nights about where older individuals fit into the natural history studies. And this is really a focus on understanding a complication of Angelman syndrome that occurs outside of that age range that we typically have natural history for. And I think there is a lot of enthusiasm from the community to be able to participate in studies like that, even if that's not necessarily an interventional study, but it could certainly lead to new therapeutic ideas for it. Certainly, that's the goal. All right, we have another great question about toe walking. So we have a young Angel, it sounds like, who walks very high on her feet and gets stuck in the feet, almost can't move, making mobility impossible. And the only way for her to get unstuck is for her to fall, which presents another problem. They've tried orthotics, but she won't wear them and gets hurt putting them on. Any suggestions?
We've been looking at this a lot in our clinic. We have a big focus on mobility and change in walking patterns over time. And there's several things that we have tried, and it really is dependent on the child. So it's hard to answer the question, but there's a few. Sometimes it's changing the orthotics to a different one that will help put their feet down. The other thing that we're doing a lot is actually casting. That's not for everybody because we have to be really careful with that because sometimes we can cause a little bit of worsening weakness. But depending on what muscle tone and things look like, sometimes that's been really helpful. And a combination of starting out with casting and then doing orthotics seems to be well tolerated. They don't like the casting at first, but then once they're used to having the cast on, it's sometimes they'll do a better job keeping their orthotics on. And so we'll do short periods of time, like 2 to 3 weeks of casting, followed by wearing orthotics to try to help loosen up those ankles. There are surgical procedures too. If it got really bad, it does not sound like it's anywhere near that bad, but we have had mixed reviews from families about how those surgeries have gone. So that release is not as challenging as some of the others with the knee. We don't recommend doing any releases higher at the knee or anything at the hips, but we have had some success with the procedures at the Achilles tendon or right at that ankle piece.
Okay, great. This is actually a nice opportunity to hear a little bit more about what your group is doing with mobility. I know you guys have recently received some funding to look at mobility across the lifespan of Angelman syndrome. So maybe give us a little snippet of what you guys are looking at and what you're hoping to see.
Yeah, I'd be happy to. So we're doing several different studies to look at gait in more detail or walking. So we do some, if kids come into the clinic to see us, we're doing instrumented gait analysis, which includes looking at the person walking at all angles and understanding what's happening with the knee, what's happening with the hip, what's happening with the ankle. And then we're doing some at-home based monitoring with some magnetoinertial units, so things that you wear on both ankles, and we get a lot of information about timing of walking and what walking looks like, where the foot lands. And we're doing that for a couple of reasons. One of them is because we're trying to figure out the best ways to treat some of the walking concerns, like walking up on toe. We're working on doing some physical therapy interventions to see what those do to differences in walking over time. And what we found is that over time, about 50% of kids with Angelman, so not everybody, but a lot of individuals, start to walk more with a crouch. So it's not a true crouch, but they tend to bend their knees and walk closer to the ground and lean forward over time. And we're trying to figure out some of the early markers of that so that we can intervene with physical therapy or orthotics or casting to really understand if we can impact that change. Because once that occurs, we have a lot of adults, and as people get into adolescence, who become less and less mobile, seem to have more pain, and that overall impacts their quality of life.
Incredible work. Thanks for doing that.
Jessica, are you guys taking any participants still for that study? I know it's funded by FAST. Are you guys taking participants still for that?
Yes. So we actually have not fully started recruiting, thanks to COVID and many other issues getting studies and things up and running.
Dang
so
COVID.
So we are just about ready to start taking individuals. So if anybody's interested in the remote part of the study, we can send you a device to any part of the country, potentially even world if needed, but if interested. But so we can do that remote part for anyone. And then the part where we're actually doing it in the GATE lab, that is a subset of individuals. And so those individuals will either have to travel or be local to get those studies done.
I love these decentralized remote assessment tools. Very cool. Maybe we can thank COVID for that, if we can thank COVID for remote. It's going to be the wave of the future. All right. So we've spent some time talking about mobility. We spent a little bit of time talking about non-epileptic myoclonus, and we can certainly revisit these areas, but we're getting a lot of questions coming in more pertaining to GI issues. So let's pivot here a little bit and talk about GI issues. So we have a great question in the chat box about safe PPIs, safe reflux meds. This is a common question that comes up. Are there reflux meds that we prefer? Are there reflux meds that we feel like are safer? When does reflux kind of rear its ugly head? Does it get better with time? Talk to us a little bit about reflux. Anybody, whoever wants to.
I would say one thing about reflux, especially if your child's older, so a 16-year-old, is to make sure there's not constipation also. Because sometimes if your child gets really backed up, that can bring on reflux even if it wasn't a problem since they were a young child. So I often even recommend getting an X-ray just to see what the belly looks like, a single view just of the belly to see if there's signs that there's a significant amount of constipation, and start with actually a clean out and get all that poop out of there before really fully starting medication for reflux at that age.
How do you like to do a clean out? Go ahead.
I think it's really important to get GI involved in this process, because figuring out whether it's constipation or whether it's just reflux is a little challenging. And I don't know that there are reflux medicines that are really unsafe for Angelman patients. And what's really important is that you do treat the reflux, because we've seen some people with some pretty destroyed esophagus. Our GI person has seen that, and we've had to put them on some really significant medications just to kind of save their esophagus. And so I think you want to be on something. I don't know of any reason why you can't use a PPI. And then in this comment, the Carafate is not really an antihistamine. It's kind of a stomach protective agent. So there's no reason why you couldn't use Carafate. I wouldn't know of anything, unless Mark knows any reason why Carafate would interact with seizures. I guess theoretically you could think maybe it would bind to an anticonvulsant and alter the absorption, but I don't know of anything specific like that.
Our GI docs generally don't use that at all. The only place that's being used actively is in the intensive care units. And I would agree with what Liz said about getting GI involved. So commonly, what I may do is just recommend that a person have a very short trial of famotidine or a short trial of lansoprazole or something like that. But if that hasn't changed, what you suspect might be the target behavior manifesting reflux, then I try to get them in to see GI as soon as possible, which means at our institution, the moment I prescribe it, I have to do the referral, because we used to have the same waiting list in neurology that GI does, and now GI is way longer than ours. So I agree. And we've had some kids who have had substantial eosinophilic esophagitis.
Yes.
That is really only identifiable with proper workup and needs a specific treatment. Mm-hmm. And I don't know of any way to know that happens without a good GI workup. Right. And many times when the therapy is instituted, there's a dramatic improvement in many domains of that child's life, regardless of whether it's a child with Angelman syndrome or some other disorder. So,
yeah, taking care of that problem can work way better than any behavioral med. for behavior in some cases, if that's really what the problem is, because basically the patient's in pain all the time.
And preventing
Yeah,
esophageal disease is important as well. That would be a much worse outcome that you would not want to have to battle.
I would just say, coming back to non-epileptic myoclonus and sleep problems, and I often describe to families with Angelman, you get in these vicious cycles where there is maybe one triggering issue, but then it impacts another domain like sleep, and then it impacts another domain like seizures. And then and it could be triggered by anything: reflux, constipation, all of the things that we're talking about, pain from the way that they're walking. And so our first step whenever we hear from families that something is off is to check everything.
So make sure we're not constipated, make sure reflux, there's no signs or, clues that it might be reflux. Make sure there's no clues that it might be pain. Address all those things. If things don't get better, then we start to think further down the list. But
right.
reflux, and constipation are probably like the top.
Definitely.
6 to 10
And
things.
sleep, getting sleep off. We see a lot, for example, kids are sick and their sleep gets off, and then they have sleepless nights, and then they start having seizures and are at risk for going into non-convulsive status. And that's when they get in these bad cycles where you really do have to be thinking about everything.
Yeah, absolutely. All right. Let's see. Any great ideas or tips for individuals with Angelman syndrome who are not big drinkers? This becomes a vicious cycle also with constipation. Not interested in drinking a lot of water, hard to do things like a clean out or increase fluid intake. Any tips?
One thing that we've done is used ABA therapy and some of the reward-based things, and have really helped get kids back on track in terms of drinking. Again, we always investigate everything. Is there reflux or something that's caused them to start to have oral aversions? Is there constipation that's impacting how full they feel, or stomach pain? So we go through that same kind of checklist to really try to understand why there's been a change in their drinking. And then if we can't come up with an answer, that's when we start thinking about behavioral interventions and working with an ABA therapist with that specific goal of working on drinking.
Great, thanks. All right, we're going to go back to ortho issues here for a second and get some of these questions checked off. Scoliosis, curvature of the spine. How common is this in Angelman syndrome? Is it something, that needs to be aggressively addressed? How common is it?
We see it not infrequently. Sometimes it's rather mild, and other times it's pretty significant. I mean, I think once it gets to the point where it's more than just a little, then you start, with follow-up with the scoliosis specialist in ortho, and they monitor it and do x-rays. And when it gets to the point that it's becoming too severe, there may have to be interventions. I don't think Angelman patients tolerate braces real well, but that's one way of approaching it. In some cases, people have we do have adults who've had spinal fusions and surgery. So that's another option. Although, of course, with intrathecal treatments heading toward Angelman syndrome, spinal fusions are a little bit of a, it could make delivery of that kind of therapy more difficult. But there are ways around that too. So
the advice I would add to what Elizabeth said is that if somebody is recommending that your adolescent or young adult have scoliosis surgery, I would get 2 or 3 opinions about that.
Yeah.
I think at many institutions that are primarily children's hospital based, the spine surgeons are rather conservative.
Mm-hmm.
Whereas at other institutions out in the community, they may be far less conservative, and it is major surgery, even with less invasive techniques that are being used these days. So
Absolutely. Great advice.
It is worth monitoring for. We've had several kids with like an S-shaped curve. So when you look at their back and you look at their spine, it looks straight. But then when you look on the x-ray, they have a very significant curve. And those tend to be kids who maybe need more significant intervention.
Fair assessment. All right, more on toe walking here. We may have answered this before this question came in, but are there any particular reasons why, or anything we know about why children might start toe walking or adults might start toe walking in Angelman syndrome? And one mom was also mentioned that maybe they should shave off the inside of the shoes. Has anybody heard of tips like that?
So toe walking in Angelman occurs for many different reasons. Sometimes it's sensory based and it has nothing to do with a difference in the tendon or the foot or anything like that. Sometimes it does have to do with over time there can be a shortening of the tendon in the back of the foot, which often can also result from the toe walking. And so a lot of times when we see some of the older kids getting start walking on toes, it's because that back of the ankle, the tendon there gets shorter. And so stretching exercises, recognizing it early and working on it with orthotics. The earlier on you get your kids in orthotics, and what we're finding, keep them in orthotics, the better they do. And I think that's where that comment comes from about shaving down the back of the shoe, because if you kind of mold the shoe with an orthotic to their foot, it can help keep their foot down. So it depends on the mechanism of what's causing it. But if you shave the back of their shoe down, then you're pushing the front of the foot up higher and the heel down lower. And so that can help with some of that tightness.
Great, thanks. Anybody else?
Young doctors like Dr. Barry Kravis and I remember a specific shoe called the Earth shoe, where the front of the shoe was much higher. I don't think anybody makes it anymore.
Interesting.
It was very popular in the 70s.
Yeah.
So.
But you can still buy zero slant shoes. They make those. So those are something you could get online rather than shaving off the heel.
And that
or get orthotics,
right. And you can actually get orthotics like over the counter now and online order, and a PT can help fit them. They don't necessarily have to go to an orthotist or a physiatrist, but that's certainly if they're there if you need them. Was this Earth shoe specifically designed for toe walking?
No, it was it was part of the 70s where it was cool to be more natural and closer to the earth.
Okay.
So,
Very cool. I'm going to have to Google.
Come around again. So.
I'm going to have to Google this when I get off. Okay, great.
Hey guys, it's Amanda here. As you know, we're here for you, our community. If you have questions about any topics we can discuss in our podcast, or if you have ideas for future episodes, we'd love to hear from you. All you need to do is email me at dearamanda@angelman.org. Thank you so much for listening and your continued support of the Angelman Syndrome Foundation.
All right, we're going to do a few quick sleep questions, and then
you have quite a bit of questions.
I know. No, we're gonna touch on a few quick sleep questions, and then we've had a question to dabble into puberty. All right, so. Sleep. Is there a particular age when sleep becomes a problem, or is this something that occurs from the beginning, or it can just occur whenever?
I don't know. I feel like it can occur at any age. I feel like the young kids have more problem with it than some of the patients as they get older. Some of the medically complex patients that are older have a lot of it, but I would say that we kind of deal with it less as kids get older.
You feel like the sleep problem.
But I don't know is whether that is because the sleep is actually better,
mm-hmm.
or because families have figured out ways to
Yeah.
adjust to the sleep issues. But the thing that I've thought about recently, because I've seen several kids that are sort of new to me, is there's a hardcore of kids with Angelman syndrome whose parents tell me, oh, sleep is not a problem at all. She goes to bed at 10 o'clock at night and doesn't wake up till 6. And I said, really? So then I really wonder if the child has Angelman syndrome, because I have this premonition that everybody with Angelman syndrome has bad sleep. But it's really not true. So if the question comes from a parent of a young child who has Angelman syndrome, keep your fingers crossed and maybe you'll be one of the lucky ones that doesn't have to deal with that in the future.
Or keep doing exactly what you're doing. If you have
Right.
done some boot camp training and you've got that kiddo on a real strict schedule and they're doing great, don't rock the boat. Very true. I always tell parents sleep training in a child with Angelman syndrome is like sleep training on steroids. And like throughout the lifespan, you have to just be continually ready to do it again after every illness, after every trip, after every little derailment. You got to be ready to go back into doing whatever you were doing that was working before. But I do strongly believe that kids can be taught to sleep. But if your child is sleeping great, there's no reason to suspect that they're absolutely going to derail and not sleep.
Transition times, though, as Liz just mentioned, are times where you definitely can see kids who were sleeping change their sleeping habits. Being sick is a big one.
Yep.
Oh, yeah.
Yeah. All right. We get this question oftentimes. Are there any supplements that are recommended for a young child with Angelman syndrome who's not suffered seizures yet? There are always a cocktail, a slew of supplements that people might have been recommended. And this question comes up a lot. Are there recommended supplements?
So this is also a very individualized question, I think, too. I don't know if I would consider it a supplement, but at our clinic, we definitely talk about diet early on, even before seizures would develop or have developed, if they're going to develop, and what the benefits are, because we definitely feel like we see benefits from low carbohydrate diets very early on, and that it's impacting other domains besides seizures themselves, and may also help be protective to developing seizures. So that would be one that we definitely talk about with everyone that comes into the clinic. Other supplements are a little bit harder to answer that question. I would say if people are interested in diet, sometimes we use supplements to help augment diet. So we have exogenous ketones that we have some data about now. We have MCT oil, which there may be some other benefits in Angelman syndrome for MCT oil. And so we recommend sometimes MCT oil, which is also a good way to naturally treat constipation, we have found. But someone asked, I don't know if this was this particular question, someone asked about mitochondrial cocktails or things like that. I don't generally recommend those. Sometimes I do check a carnitine level. That would be one that, particularly if they're on diet, it can be helpful to be on carnitine if the levels are low. And so sometimes we'll check those levels and treat if the level is low. Perfect.
And let's take a quick 3-minute. And for a family has no idea what you're talking about when you say we talk about diet, what are they hearing about in the community? What's the 3-minute overview of diets and Angelman syndrome?
Yeah, so we think that there are benefits to low carbohydrate, higher protein, higher fat diets. And we, in our clinic, depending on if someone hasn't had any seizures, we'll start with a little bit less restrictive diet. So it's usually about 40 to 60 grams of carbohydrates a day. And the principles behind it are to switch over metabolism. So if someone's using more fat-based metabolism as opposed to sugar. And that does seem to be helpful. In particular, the data is there that it's helpful for treatment of refractory seizures, not just in Angelman, but many different types of epilepsy. And then like I said, we think we're seeing benefits for other aspects of Angelman.
Awesome. Thank you. All right. A couple of questions here about other medical complexities in Angelman
Can
syndrome.
I jump in really quick and just let people know that there will be a whole session on diet on Sunday?
Perfect.
Oh,
Great.
Saturday. I'm sorry.
I was going to say. Great. Perfect. Okay.
Okay. Liz, can I add one thing
Please.
to the
Yes.
supplements thing?
Yes.
This is separate from diet, but in about 10 years ago, Sarika Peters did a survey of several hundred Angelman families through the NASF-based questionnaire that looked at folic acid, melatonin, B6, magnesium, DMG, carnitine, low dose naltrexone, and omega-3 fatty acids.
Okay.
And they looked at what percent of them felt that it had shown improvement or no improvement. The vast majority of all of those compounds were judged by the families to show no improvement at all, except for melatonin. Melatonin was the only one where the majority of individuals felt that it helped with the overall picture of the child. So, so if you have any hesitancy about feeling bad about not using those supplements, your predecessors should reassure you that you can save money at the health food store
I love
by
that.
not buying that stuff. So,
Thank you for pulling that out of the archives. That is very helpful.
I don't know it was ever published, but it was a
great.
cool study.
Anecdotal, absolutely.
Although
So-
there's one specific situation where a supplement is known to be helpful. If you're on Keppra and you're having behavior problems, it seems that B6 helps ameliorate those. But that's in that very specific situation. It's not generalizable to everything.
Absolutely. Thank you for that. All right. Is it common for individuals with Angelman syndrome to develop more health concerns as they get older, like heart conditions, other things like that?
I'm seeing a fair number of patients who are over 40, and I have not seen anyone with heart problems. That doesn't seem to be an area that deteriorates. Certainly motor function, the non-epileptic myoclonus, sometimes even swallow, scoliosis, mobility, all of these things are problematic as patients get older, but I haven't seen anyone with a heart problem.
I would agree. I've never seen that either.
Great. Agreed. All right. As far as seizure monitoring, are there specific seizure monitoring devices that seem to work better than others for kids with Angelman syndrome or adults?
I don't know of any specific study of using different monitoring devices for individuals with Angelman syndrome, but there's a couple of FDA-approved devices. One of them is an item that's about the size of a traditional computer mouse where you strap it on to the bicep, and it's done for monitoring for convulsive seizures in sleep. And I think it's only approved for use in adolescents and adults. The most commonly used is a device called Empatica Embrace, which monitors seizures by using an accelerometer that looks at wrist movement and also looks at change in skin electrical conductance like one would do in a lie detector. And those are about as sensitive as they can get. The issue with all of those devices is that there's a lot of false alarms. You can activate the accelerometer part of it on the wrist just by stirring a cup of coffee. So I don't really know if anybody's tested it in kids with Angelman syndrome, but it's something that people are concerned about, mostly because their child may be sleeping in another room and so forth. I personally don't know that the risk of sudden death is substantially higher in individuals with Angelman syndrome and epilepsy than it is in another group of individuals who have uncontrolled seizures. I mean, it certainly can occur, but if you choose to look into that, be ready for some major changes in your lifestyle. Some insurance companies will cover the Empedica Embrace and others may not. So,
Do you have families that feel like they found it helpful? Do you think?
not any Angelman families.
Yeah.
Some other families of kids with chronic epilepsy who the main thing that it does is it eases their anxiety,
Sure.
but those devices have never really been proven to prevent sudden death in patients with uncontrolled epilepsy.
Right.
So,
Thank you. All right. Let's talk about mouthing and chewing behaviors. These are incredibly problematic for families. Any tips, tricks, treatments?
It's often sensory seeking, so trying to find other ways to fulfill that sensory need can be helpful. So carrying around, I don't know if anybody, like a little rabbit's tail thing that you can buy has helped some of our patients. Also spinning things, so fidget spinners. Some people have tried Chewies, but of course that's just putting something else in your mouth. So if you're trying to get away from that, like distracting things that provide some of that, those sensory help can be good.
Great. Any other tips?
Yeah, I think that's mostly it. We don't have a great treatment for it yet. That's one that needs to wait for genetic therapy.
Yeah. More UBE3A. That'll help.
Do you think that this is something they're going to address in the anxiety talk tomorrow night? Because like Jessica said, I do think it's a lot of sensory induced or anxiety.
And anxiety.
So yeah.
Absolutely. It's something to bring up there. All right. Do we see changes in cognitive skills as angels get older?
I would not see that we see improvement in the adults with Angelman syndrome. It seems that most patients are kind of on a static, in a static situation where they kind of do what they do. And I think the data from the natural history studies really supports that there's just a very flat cognitive curve after a certain point.
Any other input?
I mean, we definitely have kids that we see as they get older that continue to gain skills. So I think it also, I think it could be very, very dependent, but they still can learn new skills. So, we have families that work very hard at it, but I think definitely the data does not suggest that there's a cognitive decline.
Absolutely. And I think cognition, as we can measure it, doesn't seem to improve, but I agree. We do hear anecdotally, certainly. And I think we can measure when we look at raw data, new gained skills, continued new gained skills throughout.
Yeah, I didn't mean to imply that people with Angelman syndrome don't learn anything after a certain point. It's more just that their relative cognitive ability relative to what's normal just doesn't go up.
and I think a scenario in which we may perceive that is for an older individual who has bad epilepsy or bad myoclonus, where they're being treated with loads of sedating drugs to try to minimize that. And so the outcome of that is excessive sedation, and then you're much less engaged with your environment. And so we try to do our best to try to minimize the burden of anti-epileptic drugs that have sedating qualities. So
Yeah, absolutely. I've seen people come in from group homes on huge amounts of benzodiazepines. It's a wonder they can do anything, and they're not doing anything. They're just kind of sitting there drooling all day, and it's a real problem. I mean, and I the number of adults who wind up on all of these drugs and then they don't have more episodes even, and somebody just decides to continue them on them forever is really large. And I think you can wean some of these medications, and then you see a lot, then you can see a kind of a jump in cognition because you're basically the patient's waking up.
Sure. Yeah.
I think that
I would add to that.
Go ahead, Jessica.
Sorry. Oh, I was just going to say, I would add to that Depakote in escalating doses of valproic acid, definitely we see kids with and adults who have decline, and stepping back off some of those medications can really help.
Yeah, absolutely.
So can I just add something else to this? Because I think that there's probably a lot of people in the audience who have adults, teenagers who don't regularly attend an AS clinic and don't have the advantage of seeing a neurologist that's very experienced with Angelman syndrome, like Dr. Barry Kravis or her colleagues at Rush. And many adult neurologists in the community are not very well informed about various medication choices for treating seizures. They're often even not well informed at all about the existence of non-epileptic myoclonus. And so Dr. Dewis and Dr. Anderson, along with a little help from their friends, have put together an article that we're hoping will be published very soon, which families could readily bring to their providers, whether it be a primary care provider, a neurologist, gastroenterologist, orthopedist, which will succinctly, in the format of a journal article, inform that individual of what are the big issues and what things you can do to help and what things you can avoid to help these adult providers take care of your your young adult. So.
Yeah, thank you for mentioning that. The other thing that's available is we now have a live 24/7 on-call Angelman expert through an emergency line. So you can call the phone number, which I can put in the chat. It's 720-777-0015. And at all times, there's someone on call for the Angelman community. During the day, we have a nurse available who will take the call and talk with the specialist on call. And then in the evening, there's always an expert on call that you can reach through this phone number. It is meant for your provider to call. During the day, we will take family calls, but at night, when the answering service is answering, it will just be provider to provider consultation. So if you're in the emergency room and you're working with someone who's not as familiar with Angelman syndrome, or during the day, if you want your provider to call, we have someone available to talk with you. And a lot of what we're doing is actually just sending out what's not yet published, but hopefully coming soon, that, some of the consensus from all the experts of how to best manage these concerns.
Perfect. Thank you. And we've got requests for the emergency number again. It's now in the chat box. I just reiterated what we were mentioning earlier about this kind of cognitive plateau. Again, the challenge with this is that we really don't have good tools to measure what nonverbal individuals know. And again, there's lots of other confounders, as Dr. Nespeka was mentioning, that these adults may be on many more medications to control seizures and non-epileptic myoclonus and these sort of things. So as these therapeutics are coming down the pipeline and we have potentially more even symptomatic treatments that are helping some of these symptoms that are causing this overload of medications, we might, hopefully we'll have better tools to be able to tell exactly what our loved ones know and can do. All right, pica, anemia in Angelman syndrome. Common, not common treatments? Does anybody recall kind of the punchline from the paper that came out of Mayo 2 or 3 years ago, looking at anemia and Angelman syndrome?
The punchline of the paper from that clinic was that when they looked at a group of individuals in their Angelman clinic who had lousy sleep, and they surveyed the ferritin levels, there was a correlation with low ferritin levels and lousier sleep. And when they treated those individuals with iron, many of them had improved sleep. So, and that's based upon an association with some degree of iron deficiency, not necessarily severe anemia, and a condition called restless leg syndrome, where they have periodic leg movements in sleep and they're kicking around a lot more, which some of your spouses may do in bed. And if they're doing that to you, have them check their iron. So,
Just eat a mistake.
but no, I thought that was a really nice serial study. It was not a controlled trial, but it's something that we can try to look into and offer. Doing a polysomnogram in many individuals with Angelman syndrome, I suspect would be a major challenge. Just having them keep all of these devices on in their nose and leads on their legs and so forth. So.
Yes, very challenging. I will say that both from a parent perspective and also from a clinician perspective, very challenging. All right, we're going to get a few more questions here answered as we're approaching the top of the hour. Thank you to everybody who has been putting all their questions in. We're planning on flying with our 2-year-old with Angelman syndrome for the first time. Is there anything that we should be concerned about seizure-wise while flying? And does the elevation change or pressure change contribute to seizures? Can it?
Yeah, I don't think that I would consider elevation to be a big factor in seizures. I think, sometimes young kids just haven't had seizures yet, and it's always possible they could have seizures anytime. And sometimes when you're on your vacation, people are a little more excited and a little more sleep deprived, and so that can be a time when seizures happen. The main issue with the airplane is that you're on the airplane, and so you can't kind of do anything about it. Like, you have to stay on the airplane until it lands. Some people take a preventative dose of Diastat or something with them, just in case. There should be the rare instance of that one time is when your child picks to have a seizure. I don't know that would be necessary. I think that's more of a security thing than a need. So I don't think flying is a seizure risk particularly.
Awesome.
I agree.
I will say at 2 years old, my child with Angelman syndrome was my best airplane buddy. She was the easiest one on the airplane compared to my other 2 children. So have fun. Good luck. It'll be great. Take a car seat. Kids do well in car seats on airplanes. All right. Let's see. We talked about anemia. Let's do a quick, we've gotten a few questions about, is there a typical time when seizures start? Is there a typical time when seizures get better? This, again, will be fully covered on Friday night in more detail, but let's get these questions answered quickly.
Either way, I think it's common for seizures to have their onset, not right at birth, but in the first couple years of life, between sort of 2 and 4. That's a common time that we see people start to have seizures, sometimes earlier, sometimes later. Some of the patients who have uniparental disomy or introgenic mutations don't have seizures at all. So there's no absolute that patients have to have seizures. And the going away of seizures is even more variable than the onset. I mean, I would say some patients have seizures all through life, and others, only till their teenage years or only for a couple of years. I mean, in my experience, it's been all over the place. And we do have a lot of, we have a wide range of, genetic causes of Angelman syndrome in our clinic across all the different types. And so I think in some of the types, it's been well shown that the seizures are less of a problem in the UPD, and the mutation patients can be quite variable, but some of them don't have seizures at all.
Great, thanks. Anything to add?
The traditional teaching about seizures in Angelman syndrome 30 years ago was that they went away when you were an adolescent. And then a survey that Ron Thiebert put together in 2009 that surveyed, I think, 300 or more families found that still about 15 to 20% of individuals in their teens, 20s, and 30s were still having seizures. So, though they were far less frequent than when they were much more of a problem early in life. So
yeah. All right. Let's see. Here's an interesting question. How common is Raynaud's syndrome or Raynaud's in kids with Angelman syndrome? Has anybody ever seen it? Or do you think these are true and unrelated phenomenon?
I haven't seen it.
Definitely see it. I definitely have seen it.
I don't see.
I definitely have seen it. A lot of kids that we see, sometimes it's not true Raynaud's phenomenon, but they're getting cold and you can see a little bit of color change of their hands and feet. So just could be blood flow in particular. So keeping hands and feet warm, wearing socks tends to help. But we not commonly, but definitely we've seen at least a handful of kids who seem to have that. And I always still do. I mean, there's other things that can be associated with that. So I still would recommend having your doctor do a workup to make sure that there's not something else that's contributing to it. But we haven't been able to find anything else in the kids that we follow with it.
Anybody else?
I don't know that I've seen classic Raynaud's. I've seen kids with autonomic dysregulation, so they do get, cooler or warmer when the environment is cooler or warmer. And I have, and some may turn a little blue, kind of like the Rett kids do. They definitely have, a lot of temperature dysregulation and turning blue in the extremities. The Angelman patients are not nearly as problematic as the Rett girls are with that. But I've just looked at that as autonomic dysregulation, basically.
All right. I mean, we could go on for hours. It looks like we're getting backed up here by the questions. Let's see if I can pull out a few more that I don't think will get answered later in the week. Interesting. These at times, somebody's asking a question about how we've seen at times pink patches around the body and the hands pink and hot. And I think that this is more of that kind of autonomic dysregulation. I think this is fairly common, these patches of kind of flushing or patches of, you've almost purplish skin or whitish discoloration at times. And Winhan has chimed in here from Boston Children's that he has also appreciated this quite often, that the hands and feet do turn red in warm environments or in cool environments, but probably not true Raynaud's and not truly Angelman. Though there's nothing to say that you could not have both things for sure. All right. Let's do one more.
Liz, can you address the COVID question?
I'm
I
trying
know
to
that's come up. It's
All right, great question. Yeah, and this is where we're going to end, and I promise we'll get questions to everybody. We will collate all these questions and we'll get answers for them and get them back out if they don't get answered by the end of the week. That COVID question just got away from me. Did you just get rid of it? Are we hearing any bad side effects? Or have we heard any side effects from the COVID vaccine in adults with Angelman syndrome who've been eligible to receive it? Or any reasons not to get it?
Yeah, in my experience, I have not seen. I mean, most of the families I know, if their child is over 12, they're vaccinated because there's more concern about getting COVID and the problems the COVID could cause than the vaccine. But that may be a function of where I live. I have not seen anyone have a big vaccine reaction.
I would second that. I would definitely recommend that kids who are eligible all get the COVID vaccine. We haven't seen any side effects in our kids that over 12 that we've vaccinated.
I would endorse that too. So.
And we've got parents in the chat box saying their adults have gotten it and done well with it. So can't get better than that.
I would also say about COVID that we've had many kids with Angelman get COVID. And I haven't seen any major challenges from COVID, major negative side effects or needing to be hospitalized. Definitely our clinic, our neurologist and all of us have really closely monitored for increased seizures, especially with fever. But most of the kids and adults that we've had that have gotten COVID have actually done okay with it.
Yeah,
Someone asked that.
I think that's true.
Yeah.
Great. Awesome. Well, Amanda, I know Amanda has a few things to wrap up, but I just want to thank everyone for their incredible engagement and all of these great questions that came. I hope that people feel like they learned some things about Angelman syndrome across the lifespan, and got some important questions answered. Again, we're going to be doing this all week long, and we will make sure all questions get answered by the end of the week for sure.
Absolutely. Those questions that didn't get answered tonight, we will make sure to answer those. Just as a reminder, tomorrow night will all be about anxiety and behavior in Angelman syndrome. So if you have questions, make sure you show up tomorrow night. And Friday night will be all about seizures. So anything you want to ask about seizures to Dr. Ron Thiebert, he'll be on there to talk about it as well. So I also wanted to, Liz, if you could just really quickly, I know we're kind of running out of time. A lot of individuals who may be on the call might be wondering, how would I even get in contact with one of these amazing specialists that are on the calls tonight? How do I get to a clinic? Can you talk a little bit about, for families who may be really wanting to get to a clinic, what that looks like?
Sure, absolutely. So as we stand right now, there are, I believe, almost 20 clinics in the United States. There's several clinics outside of the United States as well. The best advice, if you're interested in visiting a clinic first, is just to go to the ASF website and look at where the clinic sites are. There's contact information listed for each of the clinic sites. So you can email or call the clinic coordinator for each of the sites, inquire about what a clinic day might look like there, what specialists they have to offer, what research opportunities, what clinical trial opportunities there might be. If there is a specific question or a specific health challenge that your loved one is having, and you're wondering if there might be a certain clinic that might be best to see, we do have a clinic coordinator who kind of helps families navigate which clinic they might want to go to. They can help navigate which clinic might be closest, or if there's a specialist, if behavior is the major issue, or seizures are the major issue, or communication, diet, et cetera, which clinic might be best within your local region to go to. Her name is Zoe Dannenberg, and her contact information is also available on the website.
I put it in that as well.
Perfect. In terms of funding for clinics, to get to clinics, usually if you're going to a clinic within your own state, private insurance certainly is usually going to pay. Medicaid will usually pay for a clinic within your own state. If you're trying to go out of state for a clinic, that can be a little bit more challenging, but your local doctors oftentimes can do basically a prior approval or a letter of medical necessity that indicates that you're traveling out of state to seek specialty care that can only be sought out of state, and Medicaid will oftentimes pay for it in that scenario. If that's not successful, there is also the ASF Family Fund that was designed to help families get to clinics and be able to get to expert medical care. And so there's twice a year applications for that. And that's something we're always pushing information out about the Angelman Family Fund, but you can contact us at the foundation anytime if you want more information about that. Also, that's on the website as well.
And that the next group of applications will be in October. So for the Family Fund, that will open up. And the goal of that was to be able to get families to these clinics. We're super proud of these amazing clinicians and this clinic network that we've put together. And we want families to be able to get to these clinicians and get to these clinics if they want to. So thank you guys so much. I'm Dr. Elizabeth Berry-Kravis, Dr. Mark Nispecka, and Dr. Jessica Duis. As a parent, I can't thank you enough for what you have done for this community, and even what you've done just for me as a parent. I think I've talked to every single one of you of like, hey, Jackson is doing this. Please help me. I don't know what to do. And so I appreciate what you're doing and your passion, not only for the Angelman community, but for the rare disease community. That's important, because what we can learn from one community, we can learn from others. So we're just so thankful for each one of you. I would ask, I know we have a couple minutes, but I've been trying to ask this question to give people who are on the call something to be excited about. What is one thing that you are super excited about for the Angelman community as we move forward?
Well, what I've been really excited about for years is the potential for true early genetic intervention, where this condition could potentially be either cured or the major features of it substantially modified so that it is a different condition moving forward. There's, the research symposium talked about a lot of, caution in moving forward with various therapies, but I think that the entities that are doing the clinical trials are being quite cautious and deliberate and not just opening up things to just have everybody have a lumbar puncture injection with an ASO willy-nilly. They're going about things very systematically and carefully. So, and I'm really glad to see the pharmaceutical industry being so responsible in that regard. So
Wonderful. Thank you, Mark.
Yeah, I would have to say that's what I'm most excited about. I mean, having run 2 of the trials now and having seen all the genetics patients and some of what went on in that trial, I honestly thought it would take years to kind of see this gradual improvement in Angelman syndrome. And some of the dramatic changes that we saw in the patients were way beyond what I expected, and I didn't really believe them. And I made people text me videos, and it's like, you spend all this time. Mark and I have been in neurology forever, and mostly we've been a diagnostic specialty. And now we get to be a specialty that can actually treat our diseases. And that is exciting. That's why I'm in the field. It's why I'm not going to retire, because
yes,
I've been waiting
you
for
have
it for
to say
30
that
years.
again. You have to say it again for multiple times so people can hold you accountable to not retiring.
Well, I've said it to the Fragile X field and the Niemann-Pick field. So it's because now finally we have, what I've been waiting for 30 years. So, we got to get it. We got to take it through.
Yeah, I love it. Jessica.
I would say that exact same thing. I think working with kids with Angelman is such a rewarding experience. You can tell that they're absolutely brilliant, and I can't wait to hear what they have to say. And I think at one time we all felt like that wasn't going to happen in our careers, and I think we're all going to see that in our career, which, there's lots of reasons to have hope and be excited.
That makes me incredibly happy as a parent. And I'm sure everyone that's on right now is probably saying the same thing. And honestly, a lot of that wouldn't happen without the support of you as clinicians, our amazing researchers that are in the field. We have great foundations that support this community as well. I mean, the Angelman Syndrome Foundation obviously works very, very hard with the clinic networks to support the community. There are multiple other foundations in this space that we have to also lift up and say thank you to. FAST is doing great work. Angelman Syndrome Alliance is doing great work. The CAS, Canadian Angelman Syndrome Alliance. There's just such this community is unbelievable. It's one that I've been very an honor to be a part of. So I'm thankful for all the work that you guys are doing, and thank you for leaving us tonight with those very inspiring words. And we're going to hold everyone accountable, especially you, Dr. Kravis, of saying you're not going to retire, right? I mean, everyone, there was 100 people at one point. You all heard it. So same with Mark, because I think Mark is like, I'm ready to enjoy the life of retirement. We're not going to let you go as well. So,
yeah.
Well, I actually am retiring in a year.
No, you're not. No, you're not.
I think.
No, that wasn't.
No.
You,
That
Tim.
was-
No,
No, I just-
can't say that.
Yeah,
I
right.
have to do that before I become dangerous.
That's
I'm
Well,
terrible at technology. I'm terrible at texting. I'm terrible at the chat box. If I didn't
love
have
it.
a bunch of younger colleagues working with me every day, I'd be lost. So,
I love it. Well, we're not going to let you go. So, but I love you guys so much. Liz, do you have any last words you want to share?
No, thank you all for your time tonight. I appreciate it.
Yeah, absolutely. Thank you guys. We'll see you tomorrow night for another wonderful panel. Have a great night. Thanks for listening to the ASF podcast. If you enjoyed this episode and would like to support us, please share it with others, post about it on social media, or leave a rating or review. And please don't forget to subscribe.